Hello, good morning, good afternoon, good evening, depending on where you're joining us from. Welcome to this week's Africa CDC briefing on health emergency on the continent. The platform is set up to facilitate weekly engagement with members of the media to provide updates on key health issues on the continent, including the multi-country MPOX outbreak in affected member states, the cholera outbreak, Ebola in DRC, and of course, other health issues that are plaguing the continent. Today, we have with us the Deputy Head of the Incident Management Team based in the DRC, Professor Yap Bone II. He's going to lead our briefing today as usual. My name is Nike Wongwe. I'm sitting in for the Director of Communication, Ms. Margaret Edwin, and I will be moderating today's section. Just to inform you before we bring in Prof. Yap, we have resumed our translation for the briefing, so you can access the briefing in French as well as in English as we proceed. Let me now turn over to Prof. Yap to begin the section. Over to you, Prof.
Thank you very much, Nick. Good morning, good afternoon, good evening, depending on where you are currently living. So it's my honor once again to take the press briefing on behalf of our Director General, Dr. Jean Kaseya, who is currently preparing a critical meeting with the minister of 16 countries, African countries, that are preparing the engagement with the US government that has just launched the America First Global Health Security. So it's critical to us as Africa CDC to move forward with our countries, with our member states, to see how we can engage in this new era. So today I will be once again giving you the temperature, the trend of how the different outbreaks and cholera, MPOX, Ebola are being managed in the continent. And I will be doing the press briefing from Accra, where African experts sit together to understand, to appreciate how we are going to change, to transform the way we implement the surveillance, not only for MPOX, but for other public health events. And once again, I take the opportunity to thank all our colleagues who are in the field, fighting all those outbreaks, relentless. So this is also the opportunity for us to acknowledge that. Over to you, Nick. So this week we have those outbreaks that we've managed, but last week was critical. We elude some few of the activity that happened aligned the UN General Assembly. And here we'll highlight some few that carry on since we had the last briefing. So there was that important roundtable on the 100-day mission, which really highlight how critical it is to harness the artificial intelligence to protect against pandemic. We really consider that artificial intelligence is an opportunity for our continent to leapfrog and ensure that the different initiatives that we implement in terms of public health care, primary health care, epidemic, outbreak response, this is a critical tool which is for Africa CDC and the continent to use. Also, innovation. It's vital to strengthen Africa preparedness and protect to our people and our community. So lastly, together, they have agreed that it's critical to push the African leadership, but also to emphasize the global solidarity. That's the only way we believe that we can safeguard the community everywhere, because when there is an outbreak somewhere, then there is no one who is actually protected. Next slide. It was also the opportunity to sign a memorandum of understanding as this one that was signed with UNAIDS to create partnership to advance Africa health security. So this is a critical step, really, to strengthen the community health system, to expand our health workforce so that we can also move forward one of the critical pillars of Africa CDC, which is the local manufacturing, and to ensure sustainable HIV response. And as we know, HIV remains a major public health challenge in the continent. So together, we can really protect those vulnerable populations by bringing care closer. And even in this MPOX outbreak, we've seen that in most of the countries, 7 out of 10, if not 9 out of 10 people dying of MPOX are people living with HIV. So it's critical that to strengthen that partnership that has been signed with Winnie Byanyima to strengthen her leadership, her vision, matching with the Africa CDC vision. Next slide. A critical milestone has really been achieved by Africa CDC. The fact that the United Kingdom approved the direct funding of Africa CDC, it's the product of a critical long processes. This underscores our commitment to transparent decision-making, robust oversight, and enhanced accountability across all levels. Just in 1 year, we've been hosting not more than 8 to 10 audits to ensure that our accountability, our process are aligned with international standards. And this recognition is actually highlighting all the effort that has been made. And for the last Tuesday in Addis, colleagues from UK agency were present in Addis Ababa to co-create how we can move forward this agreement so that we can streamline the future of our collaboration. Next. Now, going back to our public health event, we still have, as you say, the same top 5 with MPOX, cholera, which we'll be talking during this briefing. We have the outbreak of measles that continue. We can say that 20 countries are affected, 18,000 suspected cases, 9,000, confirmed case, and almost 1,000 people that have been dying of measles. Dengue is still a challenge, Lassa fever as well in some 4 member states. Next slide. Going back to DRC, where the IMST is operating, the Ebola outbreak is continuing, though for the last 6 days, we've not been having a confirmed case, which is great, highlighting all the effort that are implemented in the health zone of Bulape with all the different partners to contain this outbreak. So far, 337 samples has been tested, 53 confirmed case, 31 deaths, which give a case fatality rate of 58%. And we still have 1 health zone, which is Bulape, with 6 aires de santé, which has been affected. Now, as you can see, the ratio of female is 60%, and we have 4 community health workers that are passed away. That was really in the early days. Now, with the support that has been put in place, with the effort on implementing the infection prevention and control of infection, also the case management has been improved, and the surveillance. You can see that the case to contact ratio is 1 to 25. Remember that we put the threshold to 1 to 20 minimum. So it's important to highlight that when we have 1 case, we have at least the 25 people around that person who are identified, who are follow-up, and you can see the follow-up is around 97.3%, which is quite good. And then those people, not only they are followed, but they are also the first target in terms of vaccination. So far, 16,000 vaccines has been deployed, 9,000 persons have been vaccinated 2 days ago. Yesterday, and some extra effort has been done. And as per today, the report that we heard this morning during a coordination meeting were around 12,000 people that have already been vaccinated, which reassure on the capacity to control the outbreak and to prevent, because we don't want to run after the outbreak, but we really want to control, to be ahead of time, and the vaccination is one of the critical tools to achieve that. Next slide. As you see now in the health zone of Bulape, you have those those 6 aires de santé at a smaller level, and you have the one of Dikolo, which is definitely the one having the highest number of cases and the highest number of deaths. So what's happened in that case is that the team doing the investigation are going there to understand the chain of transmission, to ensure that there is no one that is missed, so that all the contacts are traced, are listed, and therefore has the opportunity to get the vaccine. And for those who are tested positive and that need treatment, then they have access to the MAP 114 that has been, remember, discovered by Professor Muyembe in DSC. Now, the challenge with the MAP 114 is that the number of those available is quite limited in country. So there is a conversation ongoing so that we can increase the number of those that can be brought to DSC. So the same thing that has been done with the vaccine, having a large number of vaccines that are stockpiled in the country, the same thing that has to be done with the therapeutics, so that we are confident that in one side we can prevent with the vaccine, and in the other side we can also have the therapeutics so that we can treat the patient, because we've realized that among the people who received the MAP 114 or Ebanga, only 35% of mortality. Some of those people, unfortunately, came late. But on the group of people that was really in the early phase that did not receive the treatment, 95% of those were dying. So it's a critical tool that need to be scaled in terms of access to the therapeutic in DRC. Next slide. In Senegal, they've reported in the 21st of September an outbreak of Rift Valley fever on the side of Saint-Louis. So far, they've been 9 deaths out of the 28 confirmed cases, with a case fatality rate of 28.6%. So just to remember that it's a vector-borne disease that is happening, and among the other, the malaria, chikungunya, dengue fever, and West Nile virus, which again re-emphasize the challenge of the vector-borne disease, but also the One Health, where we have to look at the health from the perspective not only of the human, but also the environment and the animal, where those insects can continue to be present and therefore transmit the virus, killing those people. Next slide. The situation of MPOX in the continent, we keep on following the decrease on the number of confirmed cases, suspected cases, but also in the number of deaths. This week, there's no deaths has been reported among the confirmed cases, which is quite encouraging. And the colleagues that are in a different room, as I mentioned, there is a workshop on the surveillance, how we move toward the transition of surveillance in the national system for MPOX. So the question now is, how are we going to consider the outbreak end? How are we going to consider countries that are endemic so that we can leave the country in a position where they can control by themselves the MPOX within using all the infrastructure, all the systems that are already in place? Next slide. Looking now at the different countries, the trend of their evolution, we can tell that the countries that are the most critical in terms of not only the increase, but in terms of the number of cases that we are seeing, Kenya, Ghana, where we currently are, Liberia. So Liberia next week will have what we call the intra-action review, where they will pause with us, supporting them, and understand how the response has been evolving. What are the critical things that need to be accelerated? And we already have some ideas based on what we've been doing in other countries, including Sierra Leone, strengthening the surveillance, the community healthcare workers, active search of the patient, vaccination, target vaccination. So those countries will benefit from those support. I mentioned Liberia, I mentioned Ghana, and Kenya, and later on you will see when we come to the vaccine that they will also receive the vaccine so that they have a comprehensive approach on responding to this MPOX outbreak. Next slide. And we have the countries, you can see, we are happily seeing Uganda, DSC, Burundi. Those are the countries that initially were the highest. CAR is endemic for MPOX. Uganda, DSC, Burundi for a long time was really the one having the largest burden of MPOX cases. So we are gladly seeing the decrease that is continuing, though effort has to be strengthened to ensure that we really go as down as possible, considering the level of endemicity that we want to achieve. Next slide. Senegal, which has reported Rift Valley fever, is also dealing with MPOX. You remember we mentioned one case of MPOX that has been imported in Senegal, and all the contacts have been followed up. Now we have some 3 cases that are not related to the first one. So that tells us that there might be a human-to-human transmission within the country. So now we have 5 confirmed cases out of 37 suspected cases. So critically, the discussion that we have with the country is to ensure that we strengthen as much as possible the containment. Remember, we emphasize the key driver to control the outbreak at its beginning. The political will, critical, the community-based surveillance, and then we also support them in availing in the coming weeks some vaccines so that they can have a targeted approach of vaccination. So all those put in place should really help the country to limit as soon as possible to control this outbreak before we see the number of cases increasing. Next slide. In Liberia, which I've mentioned, they will have next week their intra-action review. They've been having so far 1,794 suspected cases, 848 confirmed cases, with no death that has been reported. But in the conversation that we have with them, they are actually investigating some deaths that might be related to MPOX. So they will find out whether it's confirmed or not. But still, it's good to see that the reduction in the number of confirmed cases, though you can see the test positivity rate is very high, 85%, which means that most of the cases are those who are found in the later stage. Also, that is a country where the home-based care is mainly used, and we've learned that when it's not properly implemented, where people are at home in the morning, but in the night, they will go and have other activities and then spread the disease. So the interaction review that is happening next week will definitely support the country on how to focus on the hotspot, Montserrado, which account for 70% of all confirmed cases. They need to have active tracing. The same find them all strategy that we implement in Sierra Leone might be also relevant for Liberia. They also have some vaccine, so combining those activity might be an opportunity for them to now all really reduce the number of cases, because this reduction that we are seeing might not be the real one because the active tracing is not happening. Next slide. In Kenya, we continue to see the increase in the number of cases. You can see that the number of confirmed cases is moving from 52 to 60 confirmed cases. Still 9 deaths has been confirmed with a case fatality ratio of 1.6%. Now, what is critical to highlight in Kenya? Initially, we were Mombasa, Busia, where we were having the corridor. And then at that time, the most target population were the truck drivers, the sex workers. Now, when you see that Nairobi is becoming the third or the second actually hotspot, it's already bringing a total different image of the outbreak and how the response need to be implemented. The country has received 10,000 doses of vaccine that has been used. So now a new allocation will be provided as I will come later on. But definitely the critical support is needed for surveillance. Once again, you see a test positivity rate of 73%, which means that the people we have positive are those who are coming in the late stage of the disease. So this support is being discussed with the country. We have a 2-hour deep dive this week with the country to ensure that we can provide, with the limited resources, we can provide support to the country so that they can address the most critical pillar, which are the surveillance, the vaccination, and the case management. Next slide. In Ghana, where we are and where the vaccination will be carried on soon, we gladly see that there is a decrease in the number of cases from 187 to 100 for the suspected case, for 35 to 28 on the number of confirmed cases. Still 2 deaths, which give a case fatality ratio of 0.3%. very good point with Ghana is the high statistical rate, high testing rate, and also a good test positivity around 28%, which means they really look for the positive, which is great. Now, while doing that, it's critical to focus on the hotspot, the Western and Greater Accra, which account for 70% of the confirmed case. Those are also the place where the vaccination will have to happen, and also all the other hotspots that has been identified by the surveillance. Next slide. In Zambia, we are also seeing an increase in number of cases. We moved from 7 last week to 25 this week. We have 3 confirmed deaths out of the confirmed case. We give a case fatality of 1.4%. The test positivity rate is 27%, which is good in terms of the surveillance. Now, they report the highest number of confirmed cases in the last 6 weeks, with an average of 11 confirmed cases per every week. So this is quite striking. This is raising an alarm on how we need to push to the support to country, especially to focus on those hotspots of Copperbelt, Muchinga, Lusaka provinces, that account for nearly 60% of the confirmed case. Now, in Zambia, 11% of the listed contact test positive. And you remember, for most of the country, we were around 2, 3, 4%. So having 11% is already a good sign also that they are actually managing to find the right contact. Next slide. Now, coming to the issue of vaccination that I was mentioning early on, we are getting to the 5 million doses delivered to 15 countries. We have still 18 countries that have granted regulatory approval. We have 12 countries currently successfully rolled out the MPOX vaccination. Malawi held the training of trainer last week, which means that the actual vaccination will be starting soon. Now we have above 1 million persons vaccinated with at least 1 dose of vaccine. Next slide. The good news now in the vaccination, and for you who have been following us for all those press briefings, today we are doing the 56. You've been following all the different episodes, the time that we were thinking that we are having only 20,000 doses of vaccine, that was last year, and recently, 2 months ago, where we were having really 0 dose of vaccine available. So now we have much more doses of vaccine. We've just complete our 7th round of allocation of 150,000 doses really available for September 2025. So Uganda will be receiving the bulk of those doses with 110,000 doses of vaccine, Kenya 20,000 doses of vaccine, Liberia 20,000 doses of vaccine. So what is important to highlight is that these doses don't come with operational funding, which means the country will have to mobilize funding at the local and the national level. And this morning we were listening how Uganda is leveraging the different pillars that Africa CDC have highlighted in the new financing era. They are relying on domestic funding by increasing the budget from the parliament, but also innovative funding, moving toward people with equity, doing some crowdfunding, but also engaging the public-private partnership. And with all their partners, they rely on existing infrastructure, and that gives them the flexibility to be in a position to absorb all those without the support of Gavi in terms of funding. So those are good practice that we are really supporting. And same thing for Kenya, Liberia, that will be receiving those, though the usual funding will not be available. So in terms of delivery of vaccine, Liberia, Uganda has received some doses last week, and then there are some pending doses for Mozambique, 26,000 that will expect to arrive on the 8th of October. Next slide. Now, moving to cholera, you can see that when we talk about cholera, though it's not the public health emergency of continental security, it's managed as the IMST. Why? Because of the figure that you are seeing. 262,000 people have been having cholera. 5,896 deaths with a case fatality ratio of 2.1%. Remember that 1% is the threshold for the case fatality ratio. So we are far beyond that. And this is a mean. As you will see, there are countries that are much higher than that. And when you compare this year, we are just entering the last quarter of the year, and we have already surpassed the total number of cases that we had in 2024. And by the end of this year, it will be 3 times the number of cases that we have in 2022. So that's why this coordinated approach is really critical to push, to accelerate how we can, in a more efficient way, respond to this outbreak. Next slide. So when you see the critical countries that we are highlighting in looking at the change, but also looking at the numbers, we have Chad, which is really critical, where we have 2,397 cases with 139 deaths. We have, of course, Angola, where you will see, we see a restart, a resurgence of cases. And then we have Burundi, which today was highlighting the challenging situation that they have, but also highlighting how they leverage on the lesson learned from MPOX to adjust the response to cholera. Next slide. In Chad, as I mentioned, we see a decrease in the number of cases and the number of deaths, which is quite encouraging, but also discussing with the country with the challenges that they have in terms of surveillance, in terms of access to some of the key environment, make it difficult to have the clear understanding of what is happening on the ground. However, we are moving forward, working with the country to have support at the different level, at the highest political level, so that it is established a presidential task force at the strategist level, where we'll support the country to improve on the strategy to respond in the surveillance, in the case management, but also critically, the challenge, the driver you can see, the movement of refugees from Sudan, overcrowded IDP camp, and poor access to water. Those ones cannot be handled by the medical, the health sector. That's why that presidential task force is critical to ensure that we provide the infrastructure for the population to have access to clean water, but also the political environment so peace can be present. There is no health without peace. That's why we are bringing all what is possible at the highest level, the AU champion for cholera, to see how he can engage with the head of state of Chad or in all the African countries so that they can actually have a multi-sectorial approach in responding to cholera. Next slide. In Angola, we see this resurgence in the number of cases. As you can see, we've moved from 227 cases to 444. We also see the increase in the number of deaths from 5 to 8. So this is critical. This is an alert. The good thing is that the lesson has been learned in the past. They have been having a high OCV vaccine coverage, which has really helped to significantly decrease the burden of cholera. But again, it's also highlighted if we don't fix the root cause of the outbreak, we can stop one outbreak, but without having a sustainable control of the outbreak, because the access to water, if it's still not there, then those outbreaks will come. And when you add on that, the flooding and the raining, then we'll keep on having those resurgence. Next slide. In DRC as well, we see with the most recent rain, we can see that there are some increase in the number of cases. From 1,206, we are moving to 2,000 this week. Number of deaths as well, from 33, we are moving to 58, which increased the case fatality ratio to 3%. This is critical. The hotspots are Rutshuru, Briza, Mwezo, Birambizo, and Kibirizi. And those are also the place where we have the challenge of conflict and displaced population. That's why one of the critical innovation in the IMST for cholera is the conversation that we are currently having with the AU Peace and Security, but also with APORA, which is a humanitarian military partner that we really want to bring on board so that they can support us on how to intervene in those very difficult areas to access. The case fatality remain very high, especially in the Equator. You can see 10%, Sankuru 9%, Tanganyika, Maindombe, while in the Kivu, they are around 2%. So 20 provinces have reported at least one case, and the South Kivu alone accounts for 17% of all cases. So it's critical to go there, but to go there, we need the space. We need the peace, and we need the support of the military humanitarian actor so that we can control the outbreak for this time, and also the multi-sectorial to ensure that the population have access to clean water. Next slide. So in summary, as Ebola is concerned, the outbreak in Kasai is continuing, though we appreciate that we've not been having a new case, which is showing that the control is ongoing. The surveillance has to be scaled so that we are much more confident. The vaccination is scaling up with today 12,000 people that have been vaccinated, which is protecting our people there. But also I highlighted the challenge of the treatment, where we need more treatment as compared to what is available. One critical thing is that with the digitalization of the surveillance is ongoing with the use of the DHS2 tracker, which give us real-time data on how the vaccination is ongoing, and soon also how the surveillance is ongoing, which is one of the key pillar to accelerate, to intensify, as well as the vaccination and the extra dose for therapeutics. Next slide. MPOX, we continue to see the decline in the high-burden countries, but we have countries like Kenya, we have Zambia, where we see the increased number of cases, and we also see Senegal, where we are moving from one cluster with one case to different cases, which are highlighting the circulation of the virus in the community. So in terms of priority action is really to implement the recommendation of the interaction review that took place 2 weeks ago in Addis. The country are finalizing the report and ensuring that they can contextualize them in the country with the enhanced surveillance, the vaccination, the cross-border coordination, and of course the deployment of the 150,000 doses that I've mentioned to Uganda, Kenya, and Liberia. Next slide. On the side of cholera, we have the resurgence of cases in Angola, in DRC. We have countries like Chad that are very high risk. And at this point, we appreciate all the effort in terms of collaboration, coordination with the different entities which has been handling cholera, which are now joining the IMST, so that we leverage on the existing expertise, so that we move as one, moving toward the 2030 cholera elimination agenda, using the political advantage, strategic, but also the operational. So Chad, DRC, and Burundi report sharp surge, as mentioned, indicating a new outbreak wave, while Angola is reporting new wave with an increased case and death, highlighting the need to sustain the response in the new hotspot. So in terms of priorities, really to continue the high-level advocacy, following up the launch of the mobilization strategy at UNGA, we'll continue engage, and hopefully we have our champion of cholera supporting different countries on establishing the presidential task force. The implement of the new incident action plan that will really be our guide on the critical action that need to be implemented. Remember that we are at an era where we need to do more with less. So with that, I will hand over to you, and I will be happy to take some of your questions.
Thank you, Prof, for that comprehensive overview of the situation on cholera, MPOX, Ebola, and the rest of the public health incidents that are happening across the continent. So colleagues, our usual means are there to send in your questions. You can write on the Q&A. You can also raise your hand on the platform and you will be recognized as well. Let's also inform you that as some of you are registering, you also send in questions. So we also go into that registration list to key out some of the questions from there so that it can come up to the platform. So let's begin our questions. There are 2 questions here we'll start off with, particularly around Ebola. The first one says, what might be the cause of recurring Ebola outbreaks in the DRC? Can a lasting solution be found, considering outbreaks of Ebola in the DRC have been coming and going for years now. Still with Ebola, the second question says, what efforts have been put in place or is being planned for points of entry or border health to try and guard against EVD importation or exportation to other member states, especially Uganda, which is receiving hundreds of refugees and immigrants and asylum seekers? Those are the two questions around Ebola. We'll hand over to Prof for response before we move to the next section.
Yes, thank you so much for those very pertinent questions on the management and the control of Ebola. The first one is, can we have a lasting solution of around Ebola? The first answer is no, because we have a one health approach. We live in one world where we have the animal, we have the environment, and when we have the human being. And the lasting solution will be to get rid of the animals that are carrying the viruses. But those animals are deep in the forest. So it won't be possible first to ensure that we have the reservoir to know exactly which of those animals are carrying the viruses and transmitting to the population. That is something that is critical. But however, we can bring it from the other angle by improving, building, strengthening the health system. We know the environment because now we are talking in Bulape. Bulape, in that area, this is the 7th time that they've been having an Ebola outbreak. Though the actual strength that we are having now is not related to the previous one, it's related to the one that happened in 1976, highlighting that is a new spillover, a new transmission. So therefore, what is critically needed is to ensure that the health system is strong, that in the hospital, the health facility, people are trained, people are prepared, people have all the infection and prevention control measure to ensure that also the community-based surveillance is working. So as soon as there is one case, they can send the alert. Once the alert is sent, the vaccine are available. The therapeutic will be available. So if we have all that, we will be able to manage Ebola as a preventable and treatable disease. Now, on the side of the question about Uganda, first of all, the current outbreak is not on the side of Uganda, but it's rather closer to Angola. So there is a point of entry at Luebo where they have been screening more than 36,000 people to ensure that none of them leave the health zone of Bulape with any sign of Ebola. Just to highlight that this is being implemented at different levels. First of all, at the district level, to ensure that the outbreak is contained within the health zone of Bulape, but also at that point of entry to ensure that there is no case that can cross to other countries, including Angola. And last but not the least, the preparedness is also happening. Angola is being supported by the different IMST member, UNICEF, WHO, Africa CDC, and so on, so that they are prepared in case they have one suspected case, they will know exactly what to do.
Thank you, Prof, for our second round of questions. Let's go on the platform. We have 2 hands that are raised. First, we have Esther Nakazi, a freelance journalist based in Uganda, and we have Kamon Point, a reporter at Politico. So we start with Esther and then Kamon. Esther, over to you if you can hear us. Esther, can you hear?
Yes, I can hear you. Thank you very
much. Go ahead.
Prof, I have 2 questions. One is, I want to know about the therapeutic that was developed by that is being used in this Ebola outbreak. Does the DRC get it at a subsidized fee because it was your own getting in there? Secondly, you said some countries are not...
Sorry, Esther, just at the end of that question, we didn't get I'm not sure if the Prof got the last part of your question. Could you repeat it, please?
Okay, so my question is about the therapeutic that was developed by Dr. Muyembe, yeah, that is being used in this Ebola outbreak in Kasai. And my question is, does the DRC get it at a subsidized fee or for free? And where is this therapeutic being manufactured anyway? The countries, Prof said there are some countries that can't get MPOX vaccines because they don't have operational funding. Can he name some countries that really don't have access this so that we understand? Thank you so much.
Thank you, Esther. Let's go to Carmen, then Prof will take that batch of question.
Thank you so much for giving me the floor. I had two questions, if I may. One was on the meeting with U.S. officials that Prof mentioned at the top of the meeting. Can you tell us a bit more about it, when it's supposed to happen, and sort of like what the aims are, in light, as you said, of the release of the America First Global Health Policy? And the second question, which is a bit broader, and I was wondering if Prof could reflect that some of the impacts that he's seen since the beginning of the year caused by the very sudden changes in global health funding, mostly due to the US cuts. Thank you.
Over to you, Prof.
Yes, thank you. Thank you so much for those different and very diverse questions. On the side of the treatment called Ebanga or the MAB 114, first of all, it's I mentioned it was discovered in DRC and in partnership with some academics based in the US, and the result was outstanding in that clinical trial that happened a while ago. But even now, as I mentioned, when we see, unfortunately, the patients that were treated that arrived early in the phase of this outbreak and that were not treated, 95% of them died. While those who have managed to have access to the Ebanga, we had a case fatality rate of 35%, which is highlighting that really this treatment is quite efficient. So the 100 dose that the country was having at the ENRB, which is still led by Professor Muyembe, is the inheritage of those clinical trials. So now the actual owner of the patent and the drug are based in the US. That's why I mentioned that there is a conversation ongoing together between the DRC Ministry of Health, but also Africa CDC will get engaged and ensuring that we can have more access to those ones. That's one. But two, also, remember that the local manufacturing is a critical pillar of Africa CDC. So we really need to take advantage of this outbreak to say, now, this is a critical tool for a disease that is happening in DRC. So the treatment has to be stockpiled in DRC in sufficient amount. So that is an ongoing conversation. And as we move forward, as we always do, we'll let you inform. So now, I've not mentioned that there are countries that cannot access the MPOX vaccine. What I highlighted, that's the doses that are currently available are available without any operational funding. So now it's upon the funding, the country, based on the epidemiology, which means their needs, and based on the capacity to mobilize resources at the domestic level, now they can absorb the dose. And I took the example of Uganda, that will receive 110,000 doses of the vaccine, thanks to the different innovation in terms of mobilization of resources at the country level with the different partners on the ground. So that is a good example of how we push the country in the future to go back to the Abuja Declaration, where the country will mobilize 50% of the GDP for health. And this can also be used to respond to those outbreaks. But clearly, it's an handicap. Some country that might not have at this point the capacity to mobilize those resources will be limited on actually requesting those vaccines, though they might need them. So we are also trying to support them on how they can mobilize those resources. Remember that Africa CDC recently opened position for finance officers so that they can support the countries on mobilizing domestic resources. So on the question of Carmen, so the meeting that will happen is not with the US official, but rather with the Ministry of Health of 16 countries. So following the America First Global Health policy, there have been designed 16 countries: Cameroon, Cote d'Ivoire, DRC, Congo, Eswatini, Tanzania, Uganda, and so on. Those countries will be piloting on how this new strategy that is coming from the US can be implemented as an opportunity, because we are moving from an era where we are seeing health in terms of aid, of charity, moving toward investment and partnership. So this conversation will happen this afternoon, led by our Director General Jean Kaseya. That's the reason why he's not able to take the brief. So the other question was on the impact of the global health financing. I will say definitely we've seen a lot of challenges in the response to outbreak. We've been talking about the sample transportation. We've been talking about the sample collection in many countries, Uganda, DRC, and so on. We've also been talking about the HIV. That was one of the reasons why the Emergency Consulting Group of Africa CDC mentioned that we are seeing a high number of people with HIV dying of MPOX, some of them because they don't have access to ARVs in some of those countries. So those critical element has been highlighted, and then the report that Africa CDC has been working on will be published soon with now the real evidence on the impact. But on the other hand, just mention country like Uganda, despite all that, they managed to mobilize local resource. Cameroon also has found some indigenous resource to actually address the gap that has been created by the reduction of international partners. They were not only the US government, as we all know, to ensure that they protected their community.
Thank you, Prof. Let's go to our third part of questions, this time focused on MPOX. We'll take these two. The first one here is from MODERATOR. He's an editor at Rwanda Dispatch, and he writes, what are some implications of MPOX outbreak on wildlife conservation hotspots areas? That's our colleagues from Rwanda Dispatch. And the second one said there have been reports of rising MPOX cases in Addis Ababa or in Ethiopia. Has Africa CDC received any official information from the government so far? This is from Adesa Getaju from our Q&A section here. Over to you, Prof.
Yes, the first one was, I think, Amiibo. I didn't get properly the name, but I think that's the one. So from our colleague from Rwanda, the implication of MPOX in wildlife conservation area. I think this is a very good question, very good, because this highlights the importance of the One Health approach. And part of the beneficiary, the implementer of the pandemic fund, which is the money that the World Bank and other partners brought together to support the preparedness and the response to pandemic, an important part has been dedicated to the One Health approach. So the FAO is the implementing partner that is handling that, with another, which is really focusing on the area of Rwanda, DRC, where we have the wildlife, to ensure that they are protected. So the impact, actually, I will say, can be a positive one, in the sense that it attracts some resources so that we can strengthen the surveillance. Because usually when we look at the surveillance, we look at community healthcare workers on the side of human, but this time it's also including community health workers on the side of animal surveillance, also including the strengthening of veterinary lab, as we've seen in Rwanda, we've seen also in Burundi and in DRC. So I think it can be seen also as an opportunity to strengthen the One Health approach and the building of that capacity. So for the Ethiopian situation, as currently we have 28 cases that has been reported with one death, if I recall well. Currently, as we are in Accra, we have the colleagues from Ethiopia. There are 3 of them from the Ethiopia Public Health Institute. They've presented the data. They've also presented how they've managed to respond in a very holistic way to the MPOX outbreak, leveraging on different campaign, the polio campaign that has really allowed them to have the mass surveillance, which is not always easy to implement. So actually, it's a good experience that has been shared to countries. And then from the discussion, they were really willing to share their data. Thank you.
Thank you, Prof. We don't see any hands, so we'll continue with a couple of questions. Okay, there are 2 new hands up, but let's take this question from our colleague Kamo Chen before we go into the hands. Kamo Chen from Mano Reporters in Sierra Leone say, given that the current Ebola outbreak in the DRC has been linked to a previous outbreak, meaning the 1970s, what can countries like Sierra Leone, which have had experience, learn from this to prevent reemergence, or if there is a reemergence, to prevent it from getting out of control, as we have seen in the MPOX case? So, Prof, you can take that one, and then we'll recognize one of those who have raised their hands.
Yes, I think this question is also linked to one of the first questions that we had, just highlighting that we cannot get rid at this point of Ebola because it's present in our environment. So the possibility of resurgence is present. It is there, definitely. As you rightly mentioned, this trend is connected to the one of 1976, which means that it's a new strain, it's a new spillover. That's how we call it. So it can happen again in Sierra Leone, of course, that has been having that large outbreak that we all remember, sadly, in the 2024, 2025. So what can be done? Strengthening the health system on being ready. And once again, I will repeat, ensuring that in all the health facility in Sierra Leone, people should be trained on how to detect, recognize those hemorrhagic fever. They need to have the infection prevention control measure in place so that in case there is one Ebola case, we don't have what we've seen in Bulape, where you have 4 people, healthcare workers, who passed away because they were the first in contact of the first case. Normally, the people should be trained to recognize the first symptom and therefore isolate the patient, provide the critical care, and of course have that community-based surveillance that can really and easily send the information, the alert at the highest level. So for me, really, the solution is to keep strengthening the health system. That is the best way we can prevent and get prepared for those outbreaks, which can happen anytime.
Thank you, Prof. Let's take from the hands. Let's take our colleague Agnes from New Vision in Uganda. Sorry, Agnes, over to you.
Thank you so much, Prof. And Nick, thank you for the meeting. So my question is about the One Health approach. Yes, you've talked about the One Health approach, and given that 70%, when we look at the African continent, we are getting disease outbreaks, with 70% being from the animal origin. So I would like to know more about this One Health approach strategy. So what is being done? What is being done to enlighten the communities affected, the countries affected, to see that we do not have this cross transmissions from animals to human beings, looking at the outbreaks that we have? And also maybe, yeah, what is being done to enlighten people about this to see that we are embracing the One Health approach to curb these outbreaks. Thank you.
Thank you, Agnes. Over to you, Prof.
Yes, so there are different levels where the One Health approach is being implemented. At the political level, I remember when I was in Central African Republic and the Minister of Health, Honorable Pierre Somse, he was really keen on the community engagement, how we can engage the community leaders on responding to those outbreaks. And then we are talking at the time of the issue of MPOX, because the concern was the population has been used to eat the wild meat, the wild animal. So now how to tell them then that they can no longer eat those ones because they could be the reservoir of those diseases. So the first thing is really how we place the community at the center of that conversation, because then we understand better what are the drivers and what are the messages we can convey at the community in terms of leaders, but then use the community healthcare workers to send the messages within the community on how to handle, because the population, if that's the only food they have to take, or if for them it's a delicacy, we should understand how to educate them in the most safe way to actually carry on some of those habits that they cannot stop. Rather than blocking them, it's critical to ensure that they have the proper understanding of the risk on how they handle those animals. That's one. At the operational level now, moving on the side of the surveillance, that's really also key to ensure that we have the surveillance at the community level where they can see when you in the village, you have some dead animal, 1, 2, 3, what do you do? Where do you report? So by engaging them and by building some bridges between the community and the surveillance and the health sector, that's how at a very low level, we really implement and ensure that the One Health approach is implemented and working before we move to all the big strategy, the laboratory and the big surveillance. Is really, for me, for us at the community level. That's why also we leverage the 2 million community healthcare workers that we want to have by 2030. We are already at 1 million in the continent. And those ones are the ones who are soldiers in the community to ensure that the right message goes to the community and also come to the community so that we handle those outbreaks together. Thank you.
Thank you, Prof. We're just 3 minutes away from time. We will take one last question from the chat here before we wrap this section up for today. This question more like linked to leveraging digital innovation. So the question is, in light of the Africa CDC's coordinated response to ongoing health emergencies, how does the organization plan to leverage digital health innovations to strengthen early detection, response systems, and community resilience? Over to you, Prof.
Thank you so much for this question. The first thing that I will mention is to invite the colleagues asking the question to register for the upcoming CEFIA conference that will happen in Durban, starting from the 22nd of October up to the 25th. There is a track, the track 4, which is actually going to handle all the opportunities and challenge around the digital health. Digital health is definitely a game changer, whether we look at it on the side of AI, whether we look at it on the side of connectivity. Now we have the opportunity with Starlinks and so on that are being used currently. Just one example now, I was talking about the digitalization of the surveillance in the response to Ebola in Bulape. Using Starlink, we have the team on the ground who are able to more easily send the information. So now, moving on the other side, where we are strengthening surveillance using what we call the DHS tracker. That's the equipping the community health care workers, the lab people with an app that they have in their phone. So, and then they can very easily insert the alert. So when there is any alert of, let's say, Ebola, they can use their phone, enter all those data, and those data will have, with one unique identifier, will be seen in the dashboard that can be accessed at different level, at the district level, at the ministerial level, at the different level. And so it's starting from the community up to the top level, where Africa CDC is really seeing a continental database, where we have dashboard, where all the countries can populate the information. And then we have one perspective of the data, because without data, there is no way we can respond to those outbreaks. So practically, the digital is being used for the surveillance on MPOX, on cholera, now on Ebola, to ensure that we have adequate data. We know exactly where the cases are, where we need to vaccinate. That is one. But also as a decision-making tool to allow the decision maker to base the procurement for vaccine, the fundability, availability based on actual resource. And at a bigger level, having a tracker that can be used by all the member states, having a continental database will make things more easier for our continent to know at any point of time what is the situation in the continent.
Thank you very much, Prof. With that response regarding the use of digital innovation, and that invitation extended to colleagues in preparation for CPHIA 2025 happening in Durban just within 2 weeks. That's all we have time for today. Thanks to all of the media colleagues who have sent in questions, diversified question, as Prof would say, just to keep the conversation going and to keep us accountable to you. We appreciate you joining us every week. At the moment, I will turn it back to Prof to close us for the section. Over to you, Prof.
Thank you so much, Nick. But I was seeing a hand from Oscar. Maybe we can give him the opportunity, because I've been seeing that hand up.
Okay, if we still have a minute, we can do that.
Just 1 minute.
I think you have a leverage from our host, so let's give you that chance. Over to you quickly. Oscar?
Thank you so much, Prof. Are you able to hear me?
Yes, we can hear you.
Yes, thank you so much. My name is Oscar from Kenya, and I want to appreciate Prof for the good presentation. My question is that I know most of us have asked the aspect of One Health approach that we need to embrace in controlling and preventing diseases. So the experience is that we need to bring on board the three arms, both from the environment, from the veterinary, and the human health. But one of the challenges we've seen, in as much as we target the reservoirs, especially for EVD control, are we really making use of the environmentalists? Are we really bringing on board in terms of rapid response? Are they part of the responses? Prof probably could shed some light in line with what's happening in DRC, so that just to understand how the role of environmentalists is in terms of the responses that we are doing in terms of EVD control and prevention. Thank you, and over to you.
Okay, thank you so much, Oscar. I will take it and then I will conclude directly. So just to say that the environmentalists and the animalists, let's call it that way, are all involved at different levels. The first level is in terms of training. So when we train our search experts, those rapid responders, we ensure that in all the countries where it is happening, next week it will be, I think in the next 2 weeks, they will have that training in Guinea. A month ago, it was in Cameroon. And when it happened, we always ensure that they are part of the training so that they are also equipped sensitized on how they can be part of that of those response. And therefore, when we now deploy, depending on the country, depending on the need, at this point, if we go back to MPOX in Sierra Leone, the issue is not One Health. It's purely a sexual transmission. But when you go in DRC in some place, then that way you will have that One Health approach in the environmental approach. So just to highlight that they're definitely part of it. We are also strengthening the wastewater surveillance, where the environmentalists are also engaged, both from the laboratory side, but also from the surveillance side. So they are critical, definitely critical on ensuring that we have an appropriate response. So with that, I will really thank you so much to all of you for being there always, all the Friday to get the information, to ask your question, and those questions are also helping us want to be accountable, want to be transparent, and to ensure that we remain aligned with the expectation of the community that you represent. So thank you so much. And then hopefully we see next week at the same time. Thank you.